As a continuation of the previous episode, this is the case of a patient who was found with absent pulse on the hallway. It's a case of cardiac arrest with asystole, meaning a flatline ECG. In this case, the only options would be CPR and multiple rounds of IV epinephrine, hoping that the patient has return of spontaneous circulation. This means when a patient regains a pulse, signaling spontaneous blood circulation after cardiac arrest, indicating that the heart has started beating effectively again. But this hasn't occurred here despite epinephrine, CPR, and ambu bag ventilation connected to an LMA, as we can see here. There is no return of circulation, no reversible cause has been found, and the young student has been providing CPR for several minutes now with no response.
Oh, shit. What? I think I just broke some ribs.
Means you're doing it right.
Third amp of Epi's on board.
Oh, come on.
Breaking ribs during CPR is not uncommon, especially in older adults or those with brittle bones. The depth of chest compressions should be 5 to 6 centimeters, and this depth of chest compressions are required to generate enough force to revive heart's rhythm and help it effectively pump blood again. This can sometimes lead to rib fractures or sternum injuries. In fact, even I have experienced this when I was an intern and was performing CPR on a patient who had undergone cardiac arrest in the cardiac ICU. The priority here is saving the person's life, as CPR could successfully revive the heart in cardiac arrest. If ribs break, you should continue compressions as long as you are following proper technique. The CPR done here looked superficial in episode 2. Here the depth is okay, I guess, since it broke the ribs, but still the CPR displayed here could have been better if it was more vertical and the movement came from his shoulders down to the patient's chest with the elbows totally straight the whole time. This was the third round of epinephrine 1 mg IV. Epinephrine could be repeated every 3 to 5 minutes. Usually if there is no return of spontaneous circulation after about 3 to 5 doses, which might be around 15 to 25 minutes of resuscitation, and the patient remains in asystole with no reversible cause, stopping resuscitation is often considered.
Call me if there's a resurrection.
Ultimately, the decision to stop CPR is based on clinical judgment, including if there is any underlying cause and response to the resuscitation. Here, the likelihood of revival seems poor. Still, it's quite incredible to see that the young doctor hasn't given up on his patient.
Hey, what's up with your asthma guy?
Responding to albuterol.
Hey, one more nabble discharge on prednisone.
They're talking about the guy who came in respiratory distress, likely acute exacerbation of asthma. He was nebulized with salbutamol, a bronchodilator used to dilate the narrowed airways, along with IV methylprednisolone, a corticosteroid that reduces inflammation in the inflamed airways in asthma. Nebulizations could be repeated according to the patient's response and improvement of wheezes, which are breath sounds heard upon auscultation due to air passing through narrowed airways. The patient would be discharged with prednisolone, the corticosteroid drug, but in oral tablets, with a metered dose inhaler containing usually a combination of drugs like salmeterol, a long-acting bronchodilator, and fluticasone, a corticosteroid.
Hey, where are we at with opening up some beds? Our Nepali lady with the crushed foot, Manu, she's still in line for the OR?
Yeah, she got bumped by your Lefort 3 fracture. Ben Kemper, he just went up. Still waiting for him to take the electrocution fasciotomy.
These are all the cases we discussed in episode 2. Basically, the most critical cases from the ER are operated first in the operating room, as only few operating rooms are available. Here, the Lefort 3 fracture case of RTA, where the guy had his mid-face detached from the skull base, has to be operated first. Then, maybe it's the case of the lady with the degloved foot, with open fracture that would be operated surgically, involving open reduction and internal fixation with nails, although this should have been done simultaneously. Then, the case of fasciotomy, where the initial incision had already been given and they would extend it in the OR for further release of affected compartments due to electrocution.
What about our OD in Central 7?
OD means overdose, which here means fentanyl overdose. The case of the child who was found unresponsive by his parents, who was intubated and had absent brainstem reflexes, signaling brain death. Basically the central case around which the episode 2 was largely focused on.
Robbie wants a few more tests. He's stable and on a vent.
Is he a candidate for organ donation?
Not sure.
Organ donation in brain-dead patients involves the recovery of organs from a patient who has been determined to be brain-dead. Organ donation can only occur after a thorough and formal diagnosis of brain death has been made. Brain death is the irreversible cessation of all brain activity, including in the brainstem, and it is considered legal death. Here, clinically, the child is in a coma with absent cranial nerve reflexes and no response to stimuli. The tests that Dr. Robbie is ordering, the cerebral perfusion study, and apnea test would also help in the diagnosis of brain death. Once brain death is confirmed, the patient's organs may be considered for donation if the family consents.
Then why is Robbie keeping him here?
I don't know. Maybe he sees something we don't.
Or maybe he's hoping for something that isn't there.
What's there is an 18-year-old kid named Nick Bradley.
Yeah, is he though? As sad as it is, that kid is gone.
Also, a patient who is suspected to be brain dead has to be observed for a set period before final confirmation. This observation period typically lasts from 6 to 24 hours depending on the patient's age, medical conditions, and the guidelines followed by the hospital. Here, during this observation period, Dr. Robbie is ordering tests to just add to the confirmation of what is clinically already a case of brain death, and meanwhile it also buys the family some time to digest the bad news, so nothing wrong here.
And if we get him upstairs to ICU, we can use that bed to actually help somebody.
Shifting a brain-dead patient to the ICU is generally done for the preservation of organs for transplantation, continuous monitoring there to preserve organs, and again, to provide time for family decisions. Hospitals follow professional medical guidelines and standards, which often require brain-dead patients to be kept on life support in an ICU for the purposes of organ donation, observation, or ensuring proper documentation and legal processes are followed, providing as much care as possible to someone's end stage of life.
Robbie is helping somebody. He's helping 2 people, in fact. They're in there right now, praying over their dead son. They just haven't let their hearts accept it yet.
Jeez, it's 9 o'clock. You're already bumming me out. Okay, let's see. Who's up next at the deli of death? Weak and dizzy? No thanks. Flank pain? Need a UA first.
He's going through the cases to basically choose the case that he finds interesting. Flank pain means pain on the sides of the back. It could be left or right, and there could be several pathologies that present with flank pain. Examples include kidney stones or cysts. These could be ruled out using ultrasound of abdomen. Flank pain could also be associated with urinary tract infection, to diagnose which a UA or urine analysis is required.
And buttock abscess. Great teaching case for a student.
Basically, a case of abscess would be a great teaching case because typically an I&D procedure or incision of the abscess and drainage of pus could be done in the ER for it to be shown to the students.
Don't make me tell Robbie you're cherry picking.
I'll take projectile vomiting in North 5 for 200, Alex.
Projectile vomiting is a type of vomiting in which the vomit is forcefully ejected from the mouth with a lot of pressure, often traveling several feet away from the person like a projectile. It usually indicates serious conditions like meningitis, which means inflammation of membranes surrounding the brain.
How are you feeling? Any pain, Minu?
तपाईँलाई कस्तो छ मिनु कतै दुखेको छ
दुखेको छैन तर पानी तिर्का लागेको छ.
So this is the Nepali lady with the degloved foot. She's saying that she doesn't feel pain, likely due to the anesthesia, which is the popliteal block given before that numbs the tissues below the knee. However, she says that she is thirsty for water.
No pain, but I'm thirsty.
Oh, nothing to drink before your surgery.
NPO, nil per oral, or nothing by mouth means the patient shouldn't be given anything by mouth before surgery to reduce the risk of aspiration. Aspiration means regurgitation and inhalation of gastric contents that the patient had eaten before from the stomach into the lungs. During anesthesia, which could cause pneumonia, also called aspiration pneumonia, usually clear liquids like water, black coffee, tea are allowed up to 2 hours before surgery, but nothing is to be given via mouth at least 2 hours from surgery. The patient is kept on IV fluids for hydration. Here, antibiotics and pain meds are also given for the open fracture.
But we can get you some lemon swabs.
Or moist swab with plain water just to address the dry mouth issue. However, in emergency situations like this, where there is an open fracture with extensive degloving injury, surgery should not be delayed for achieving NPO status if the condition is life or limb threatening. In these cases, the patient should ideally be immediately shifted to OR regardless of the NPO status, and anesthesia teams would use rapid sequence induction to minimize aspiration risk. Patient needs immediate open reduction and internal fixation of fracture and also debridement of the grossly damaged degloved leg in a surgical setting by the ortho team. Oh, so he intubated the patient. For context, this patient had suffered from pneumonia, where the organism had disseminated throughout his body and caused a state of widespread inflammation with decreasing BP, also called septic shock, and he had suffered from pulmonary edema, which means fluid in the lungs, likely an acute respiratory distress syndrome or left heart failure with progressively decreasing oxygen saturation. The only method left was intubation here. However, the catch here was that he had already signed a DNI as a part of his advance directive, which means do not intubate at the event of respiratory or cardiac arrest. Although doctors are legally obliged to follow a DNI and honor the last wishes of the patient, the proxy here, or the patient party, insisted in intubation and putting him on a ventilator machine. Now, this conflict of interest would require a legal and ethics discussion, and that would kill time, and likely the patient would die waiting for the final decision. So Dr. Robbie here decided to avoid the legal hassle and decided to intubate the patient. This is not something a doctor would ideally do, as he is not legally allowed to, and this was done due to the limited time frame during which the patient could die if it was not done.
How long before we might expect to see some improvement?
It could be hours, it could be days, it could be never. I don't expect anything for a little while.
There is a slim chance of improvement of a critically ill patient who was intubated, and it's definitely not as common as we would think. My personal experience in the ICU, and I have seen only a handful of patients who got out of the ventilation and were successfully extubated and could breathe normally and improved.
Why don't you guys go get a cup of coffee in the cafeteria, maybe something to eat? I'll have a nurse call you if anything changes while you're out.
Thank you. We appreciate that.
I'm not leaving.
Suit yourself. I'm gonna get a cup of coffee.
Ideally, a case of intubation and ventilation requires ICU and shouldn't entertain visitors as frequently due to the risk of cross-infection from them to the patient.
Could I get your eyes on a sickle cell crisis in South 21?
Headed that way right now.
ICU's insisting they still don't have rooms available.
Bullshit. Esme recon for me. Send our electrocution Victor Hunt up there until the OR is ready, please. Thank you.
Sending a critically ill patient from ER to the ICU is always a hassle, because if the beds are limited, a less critical patient in the ICU has to be shifted to the ward to make the bed available for a new patient in the ICU, and that does take time or may not happen anytime soon. Now, the patient has to be taken care of in the ER itself, which isn't ideal, as the patient requires critical specialized ICU care. Dr. Robbie is probably alluding to sending the patient to an area where more specialized care is provided in the ER itself temporarily until an ICU bed opens up.
Third epi on board?
3 minutes ago.
How long has he been going at it?
10 minutes in here, possibly 30 minutes of prior downtime.
It's just about when the doctor decides to declare death at this point.
Don't suppose you'd let me try a pericardiocentesis?
For what?
For practice. In case it's tamponade.
None seen on ultrasound.
Pericardiocentesis is a procedure where excess fluid from the pericardial space is taken out via a syringe, usually an ultrasound-guided procedure in cases where there is excess fluid buildup, like in a case of cardiac tamponade. Successful pericardiocentesis has been shown on episode 1. Don't miss that out, so go and check episode 1 breakdown as well. However, the point here is about practicing medical procedures on deceased patients in the ER, or more often in the ICU, after the death has been declared. The first thing is, you gotta respect the deceased, so informed consent must be obtained from the family members or legal representatives of the deceased person before using their body for educational purposes like this girl wants to.
This is a teaching hospital.
It's not a cadaver lab.
What do you call this?
Not only this procedure, but any procedure like learning intubation in the ICU or even inserting a central venous catheter. All of these procedures should ideally be practiced on cadavers in a cadaver lab. This is a standard practice in medical education. Or even better, advances in medical simulation technologies allow students to practice procedures on simulated patients in virtual reality. So, training on deceased patients in the ICU or ER is not morally, ethically, and legally right.
Do you need a break?
I'm fine.
You don't look fine.
Hold compressions.
After 2 minutes of chest compressions or every 2 minutes of CPR, a brief pause for rhythm check could be done, usually for less than 10 seconds, to see if the heart has started beating again. Typically, the ECG leads would show electrical activity during CPR on the ECG monitor, and once it's stopped, the ECG has gone flatline again, which means there is no return of heart rhythm here.
Still no rhythm.
Okay, Whitaker, I think that's enough.
It's been 4 minutes since the last epi. 1 more minute, please.
If I look at this situation, I would call this continuation of CPR despite no hope as the fear of letting your patient go. Experiencing the death of a patient whom you were in charge of, had talked to, and built a connection is extremely difficult, especially as a young doctor. This reminds me of a case in the ICU that breaks my heart to remember still to this day. So, this was an old lady who had been suffering from complications related to COPD, which is basically a lung disease where the airways get narrowed. Now, this patient had been in the ICU for a few days, and I was looking at all the chest cases at that time in the ICU. She was on BiPAP. We discussed BiPAP in episode 2 as well. Basically one of the measures of ventilating the patient. Her saturation started dropping, and she was prepared to be intubated. She was in distress. I was nebulizing her. As I was leaving her after nebulization, she grabbed my hand and said to me, "I think I have met death. This is my last stage. I don't think I would survive. Please let my son come in. I want to see him once." I told her to wait and then let his son come in. She was eventually intubated, and after a few minutes, she went into cardiac arrest and was declared dead after CPR. I was in shock at first, but eventually it was very difficult to digest the death of a person whom you had talked only a few minutes before.
Hey, where is she? My friend, she's in my car. She won't wake up. Okay. Mateo, Bernie. What's her name? Jenna. Come on, Jenna.
So, this is called a sternal rub. It's a painful stimulus given to assess responsiveness in an unconscious patient by rubbing the sternum. You could do a trapezius squeeze or a nail bed pressure as well. All of these are painful, and if there is no eye, verbal, or motor response to this, then the patient has GCS of 3, which means deep coma.
Wake up for me, baby. Pupils pinpoint. I need...
Narcan.
Yeah. Hold her head back, Javadi. Okay.
If you've seen episode 2 breakdown, you know what's happening here very clearly. The patient has pinpoint pupils, which means the pupils are constricted, typically less than 2 millimeters. Now, this could be due to pathology in the pons of the brainstem like pontine hemorrhage as well, but since there is no history or signs of trauma here, we would naturally suspect a case of opioid poisoning with drugs like heroin, fentanyl. To rule this out, we would provide Narcan or naloxone, which is an opioid antagonist used to reverse opioid overdose, typically a nasal spray as is used here. If pupils respond to Narcan by dilating, then we would suspect an opioid overdose, just like the case of the 18-year-old brain-dead patient in the ER already. This definitely is the fear of letting the patient go, which I can completely resonate with. And being emotional here is completely fine.
Not responding to Narcan. We might need to intubate.
Not responding to Narcan means the pupils didn't dilate and still remained constricted. There could be a delayed response to Narcan as well, but if this indicates a non-response to Narcan or a high dose of the opioid drug, the respiratory depression would also likely not be reversed, and the respiratory failure here would ideally be taken care of in that case by intubating the patient. Only time will tell.
Find a room and open a crash cart.
I can't find a carotid pulse.
This absence of pulse in a major vessel such as the carotids could mean that the patient is also likely in cardiac arrest, maybe due to the respiratory arrest causing hypoxia, I guess. Let's see further.
5 minutes since the last epi.
Okay, that's it. Hold compressions.
So, the death has been declared. An ECG print would be done showing asystole after this.
Welcome back. She's okay.
So, what just happened here? We went from an array of grave diagnoses for this patient who likely looked to be in respiratory and cardiac arrest, and now she is alive. Interestingly, opioids can also cause this kind of temporary arrest where the patient either wakes up suddenly after a brief period of apnea as the dose of the opioids wear off on the body and patient breathes spontaneously. Or more likely, what happened here was that naloxone rapidly reversed the respiratory depressant effect of the opioids in her system, and all of a sudden she started breathing again with the help of reversal of this depressant effect by naloxone, leading to sudden arousal and confusion.
He took his wife out for dinner last night. For her birthday.
Okay, why doesn't everybody take a minute, go check on your other patients? We'll meet back here to debrief with Kiara.
This is a state of shock at what just happened. Sometimes it's crazy to think how everything changes within a span of minutes, and it's difficult to digest the fact that life is extremely short and anything could happen to anybody at any moment. And I am sure that practicing medicine teaches this better and quicker than in any other field.
Bedford? Where the hell am I? Pittsburgh Trauma Medical Center. Why? Your friend couldn't wake you. I'm right here, Jenna.
Came to with one spray of Narcan.
What'd you take, Jenna?
Nothing.
You had to have taken something to cause this.
Okay, no, I was just up late studying and I just couldn't fall asleep.
So you took something to help you sleep? We need to know in order to treat you properly, okay? Do you know what she took?
No.
This could be a sign of something really serious, and we're gonna have to do a lot of tests that you
Okay,
really
I
don't...
took like half a Xanax.
I love how every episode is very interconnected with familiar cases. From previous breakdowns, we have already learned that Xanax is a trade name for alprazolam, a drug under the class benzodiazepine. Xanax is short-acting and is commonly used to treat anxiety disorders. Xanax will cause sedation, drowsiness, and somnolence as a side effect, but is not typically prescribed to help with insomnia. If insomnia is due to acute stress, anxiety, or panic attacks, a doctor may prescribe Xanax for temporary relief. However, there are drugs like Zolpidem, a non-benzodiazepine, for short-term treatment of insomnia only as well. Also, Xanax is highly addictive and will cause dependence, tolerance, and withdrawal if used long-term. With all this being said, in recent years, some black market pills, including counterfeit Xanax, have been found to be contaminated with fentanyl. We've learned that fentanyl is a powerful synthetic opioid, up to 50 times stronger than heroin and 100 times stronger than morphine, and this could cause these type of symptoms. Let's see what's here.
That's not nothing. It's okay. Okay. You taken Xanax before?
First time.
Okay. Take a deep breath for me.
So, she is not a long-term Xanax abuser at least, so no dependence or tolerance or withdrawal here. I would still think this is a contamination of Xanax with fentanyl because Xanax won't cause pinpoint pupils.
Come on, man. You heard Dr. Robley. Let's take a break. Grab a coffee.
No, I'm fine. Thank you. Did you know him?
No, I did. Did you?
Just met him. He was my first patient to die.
I'm sorry.
As we guessed before, this indeed was his first patient to die, hence the roller coaster of emotions here. As we see more and more deaths, we do become somehow desensitized to it, but still the death of a patient whom you talked more or help investigate is hurtful no matter the experience.
Are you okay?
Yeah.
You sure?
Yeah. I just remembering the first time that on occasion I have an emotional response to death. It's
Gotta be kind of tough for a doctor.
at times it can be.
Just so the job of a doctor doesn't impose excess emotional toll like this, people say you gotta have emotional detachment with patients, but it's difficult to develop because we are humans, and humans are supposed to build emotional connections when talking to other people. It's easier said than done. May get better with time, who knows, maybe not.
At least I'm not a pathologist.
The pun here is that pathologists often have to examine tissues from dead patients, or it could mean that she is in a clinical specialty with hands-on experience with patients, something that would be absent in fields like pathology.
I was joking.
Oh.
I have nothing against pathologists.
Yeah, no.
The radio density right below.
Is it pneumonia?
Possibly. Or just changes from vaso-occlusion of the sickle cells.
It's called acute chest syndrome.
We briefly touched through acute chest syndrome due to vaso-occlusive crisis before as well. It simply means that if the blood vessels in the lungs start getting clogged with sickle-shaped RBCs, there would be lack of blood and oxygen supply to lung tissues, meaning ischemia and hypoxia. This could cause necrosis and inflammation of lung tissue. The chest X-ray would typically show pulmonary infiltrates, which mean areas of the lung appearing denser or cloudy. These infiltrates represent lung tissue that has become filled with exudates, meaning fluid, often due to inflammation or tissue damage. Now, this could be superimposed with bacterial infections like pneumonia that further complicate the condition and appear as similar infiltrates on X-ray. The radiodensity noted here, which is not where he pointed, but a bit below, showing whitish changes, are pulmonary infiltrates in the right middle lobe, signaling either vaso-occlusive crisis-related inflammatory changes or pneumonia-related inflammatory changes, or both, in that lobe.
I'll cover you with antibiotics just to be on the safe side.
Yeah, we've been through this before.
Exchange transfusion is going on here, where the sickle-shaped RBCs are being taken out and replaced with normal RBCs to prevent more RBCs from getting destroyed in spleen and restore normal RBCs and hemoglobin.
Third generation cephalosporin and a macrolide?
Perfect. You're in good hands.
So, since this could also be a pneumonia right now, or the patient could contract hospital-acquired pneumonia in the future, as the patient is prone to, just to be safe, we use antibiotics like third-generation cephalosporins and macrolides. These are a class of antibiotics. Examples would include ceftriaxone and azithromycin respectively. These are used to treat the case of pneumonia or prevent it from being contracted.
Can I do a chest tube?
Which patient?
Any. I've just never done a chest tube before.
Are you really asking me to reserve any incoming injury requiring a chest tube for you?
Not all of them. I'd be more than happy just doing one, but...
Yeah, you gotta be confident enough to ask for opportunity to perform procedures, but there's an appropriate time and place for it. Also, her personality seems to be very condescending to her fellow doctors, as well as attendings. And this doesn't go very far without being met with harsh criticism coming her way soon. Medicine is a teamwork, so you would find all sorts of colleagues. I would suggest to the young doctors to stay away from people who display unnecessary ego and negative energy at work and are unnecessarily harsh and condescending to you, as that disturbs your mental peace.
Hey, if you wanted to give me more, I'd be fine with that too, but that's up to you. I'm down for anything.
Confidence and ambition are great attributes, especially when paired with respect and humility.
Medicine is going to be tough if your seniors don't support you, as most of what you learn is from seniors, so you gotta respect your seniors, your fellow colleagues, as well as your patients.
Okay, what else? What else went well?
We checked for reversible causes of cardiac arrest on ultrasound.
So, we have discussed those reversible causes as well. Tension pneumothorax, or when the air gets trapped in the pleural cavity and start expanding leading to lung collapse. Pericardial effusion is fluid in the pericardial space. Too much fluid could progress to cardiac tamponade, affecting effective relaxation of the heart due to the pressure of the fluid around it. Ultrasound scan is done for any free fluid collection in the body.
Okay, good. Does anybody have anything that they wish had gone differently?
In the hall. You should have been on a cardiac monitor. We would have caught the arrest right away.
Yeah, so the monitor would have shown a flatline ECG or asystole or an arrhythmia right away, and resuscitation efforts would have delayed and prevented the resulting hypoxic damage to the brain and brainstem. But it was too late when he checked the pulse, and his brain tissue had already died at that point due to the resulting cardiac arrest and low cardiac output.
That's true. But there was no indication for monitoring. And we now know that his abdominal pain was not from his gallstones, but from unstable angina due to coronary artery disease.
Then we should have admitted to cardiology.
So, the patient had unstable angina. Angina refers to chest pain or discomfort caused by reduced blood flow to the heart. We call it myocardial ischemia. There are basically three types of angina. There's the stable angina, where the pain occurs only when the patient performs strenuous exercise or exertion, like walking up a hill. It would typically be reduced by rest. Then there's the unstable angina, where the pain occurs even at rest, for longer duration, and won't be reduced with rest. Here there's partial occlusion of the coronary artery due to rupture of the plaque that's obstructing it. The interesting thing about unstable angina is that since there is no death of the heart tissue as such, the troponins won't be released into the bloodstream, so the troponin was negative here. The ECG might show changes like ST depression, but could also be normal. So basically we are left with just a clinical diagnosis at this point, just based upon the symptoms of the patient. And due to the tests being all negative, nobody could pick it up to provide treatment immediately.
We did an EKG, we did a troponin.
From my personal opinion, what likely happened in this patient is that this unstable angina and myocardial ischemia slowly progressed into myocardial infarction, which means the heart tissue eventually died, starting from the inner side of the ventricle and later on involving the whole of the ventricular wall, called as transmural infarction, transmural meaning full wall thickness. This event likely occurred after the tests were ordered when the patient was just waiting in the hallway. Now, this myocardial infarction or heart attack would have been picked up by the ECG as ST segment elevation, and also the troponins would have been positive if blood was drawn after that. Now, this should be promptly diagnosed as ST segment elevation, myocardial infarction, or STEMI, and stopped on time by opening up the blocked vessel via a procedure called PCI. If not, like in this case, this death of cardiac tissue will progress further to disrupt the cardiac conduction and complicate into fatal arrhythmias, ventricular fibrillation, and cardiac arrest. Eventually, the heart completely loses its electrical activity and stops, which is called asystole. It was only at this point where the young doctor identified the patient as having no pulse.
He had a heart score of 3. Who can tell me what that means?
1% chance of an adverse cardiac event in the next 30 days.
Standard of care is to discharge with outpatient follow-up.
At the point of having an unstable angina, the patient had a heart score of 3. The heart score is a clinical assessment tool used in ER to risk stratify patients with chest pain and determine their likelihood of having a major adverse cardiac event, also known as MACE. MACE could be an MI or sudden cardiac death. Both occurred in this patient here. This is the chart showing the criteria. So his score was 3, likely 1 each out of each history, age, and risk factors. Now this shows the interpretation of the heart score. Here, a score of 0 to 3 means lowest risk of a MACE within 6 weeks. So the likelihood of a heart attack requiring PCI or sudden cardiac death happening, at least according to the score at that time when he was in the hallway, was very low. So nobody suspected a major adverse event, and he was about to be discharged right from the hallway with an outpatient follow-up a few days after. So that was the protocol, and this avoided any suspicion of a cardiac event anytime soon. But the undiagnosed unstable angina rapidly deteriorated, and he died due to its progression to MI and its complications.
He was your patient, Dr. Whitaker. Would you like to say something before we all take a brief moment of silent reflection?
Only if there were more beds to constantly monitor the patient in the ER, this death could have been prevented, even if it seemed like there was no indication for monitoring, and there seemed like no rationale for suspicion of angina. Still, the monitors could have picked the ECG changes and ST elevation signaling heart attack. This indicates that for every patient presenting with abdominal pain, don't just think about abdominal causes. Also, suspect an angina or a heart attack and put the patient on a monitor ASAP, because cardiac events are unpredictable.
He like Kentucky bourbon?
Okay, good. Me too. Anything else?
I don't know, I just met him. No, he seemed nice. He was married. That's it, that's all I got.
I spoke with his wife. She's on her way here. If anyone needs to talk about this some more, I'm available.
For now, let's harness some good thoughts here for Mr. Milton.
The moment of silence is a way to show respect for the departed soul, while also acknowledging the efforts of the medical team.
How are you feeling on this?
I mean, not good. I was just talking to him. Now he's dead.
It's the hardest way to lose a patient. Always hurts.
The first time I experienced this, I was like, is this life? You were there talking to me a few minutes ago, and now all of a sudden you are gone and everything is over? How do you even process this harsh reality of life? Is this death? Now everybody moves on after this to take care of other patients as if nothing happened. How do you digest that it's a normal thing to occur here? Even worse, how do you tell family members the bad news who look at you with glimmers of hope that their beloved would recover as they had invested so much on the patient that you took care of?
Especially when it's your fault.
This was not your fault. This was nobody's fault. No doctor on the planet could have caught this.
Yeah, an unstable angina is a tricky one for sure. Also, no chance of it getting caught when it progressed to a heart attack in the monitor because the patient was in the hallway due to no beds in the ER. Also, an unstable angina could directly trigger arrhythmias as well, causing sudden cardiac death. So, anything could have occurred in this patient and it's nobody's fault. This feeling of guilt, whether I could have done something better for the patient or diagnosed his condition accurately or ordered more diagnostic tests or administered this medication instead of this This is what keeps the mind in a constant state of guilt. But at the end of the day, you just gotta admit it and move on.
Listen, it sucks, but today was this guy's day to leave this mortal coil. 150,000 people die every day in the world, and you got one of them. But you learn to live with it, you learn to accept it as much as your own mortality, and find balance if you can.
You found balance?
No, not even close. But you keep trying, which is all you can do.
This just means that dealing with death doesn't get as much better with experience as we would think and expect.
Okay. You're gonna recover. Okay?
Good luck. But wait, what happens now?
We monitor her heart and breathing for the next few hours to make sure she doesn't need more Narcan.
That's it?
Yeah. You should text your friends. How you should text your whole college. Tell anyone to listen to not take pills without a real prescription unless they want to end up here.
Seriously, fentanyl is everywhere. It's in everything on the street these days.
Okay, so our guess was right. It's a case of Xanax contaminated with fentanyl. Its misuse, getting it from an unauthorized source and without a doctor's prescription for its short-term effect of inducing sleep, instead caused the overdose of fentanyl mixed with it. She went into respiratory depression due to fentanyl and a temporary state of respiratory failure and cardiorespiratory arrest. Narcan took time to show its effects on pupils, but eventually the nasal spray worked. Her sudden arousal from Narcan or naloxone means that naloxone reversed the respiratory depressant effects of fentanyl. She started breathing on her own again and woke up from her state of arrest.
So for the apnea test, we keep him on 100% oxygen, but the ventilator won't be giving him breaths.
For how long?
For 10 minutes.
Apnea test is one of the tests done to support the diagnosis of brain death. Here, first the patient is oxygenated with 100% oxygen. Now, the level of carbon dioxide in the blood will be measured. It would be typically within normal limits, that is partial pressure of CO2 equals 35 to 45 millimeters of mercury. Now the ventilator will be turned off, meaning no mechanical breathing here. But the oxygen will still be given. We are intentionally trying to increase carbon dioxide levels, also called hypercapnia, and see the brainstem's response to the rising carbon dioxide levels in blood, which should typically be an effort to throw out this carbon dioxide via spontaneous breathing. So the patient is monitored for any spontaneous respiratory effort for 10 minutes. Now this spontaneous respiratory effort would include chest wall movement, accessory muscle use, or nasal flaring. If any breathing effort is detected, the test is stopped, and we would declare that the patient is not brain dead, because there is spontaneous breathing effort from the brainstem. If not, after 10 minutes, an arterial blood gas analysis is done, and partial pressure of carbon dioxide is measured. If it has increased to more than equal to 60 millimeters of mercury or 20 millimeters of mercury increase from the baseline without any respiratory effort detected throughout the 10-minute period, this means that even the rising carbon dioxide levels are not able to stimulate the brainstem's respiratory centers to carry out spontaneous breathing to remove the excess carbon dioxide from the blood and lungs. This means that the brainstem is unresponsive and has died.
We'll monitor his carbon dioxide levels, and if they come back way too high, then we'll know that his brainstem is not telling him to breathe.
And that means?
That would mean that there's no brain function at the most fundamental level.
As we said, 10 minutes of observation with no respiratory effort plus high carbon dioxide levels after 10 minutes. At that point, we would say the apnea test is positive, which means the brain death is confirmed.
Princess will monitor him, and I will come back as soon as we know the test results.
Okay.
Yeah.
Okay.
Now, the other test being ordered is a cerebral perfusion study. Basically, if there is no blood flow to the brain here, it also confirms brain death. Besides this, an EEG would also show no electrical activity.
This is Hank.
What happened?
Oh, nothing. We were just framing, and my buddy Joey comes in. He says a guy walks into a bar with a nail in his head, and then he points his nail gun at my head. So what would you do? So I freaked out, and then in the ensuing melee, shoots me.
Melee?
Tier 1 trauma now?
No, sir.
Whoa, definitely intracardiac.
I gotta tell you, this hurts.
Intracardiac means the nail has potentially hit the pericardium, the surrounding of the heart, and potentially the heart as well. Depends upon the depth of the nail here. The heart is typically placed behind and to the left of sternum in the ribcage.
Let's just try and relax and dial down the F-bombs. We have children in here.
Hey, you want me to stop swearing? Take the out of my heart and please something for the pain.
Stabilize the nail.
Now, just talking about the potential pathologies in this case where a nail has pierced the chest in the area of the heart. The first thing that I can think of is if the nail actually reaches the heart muscle and pierces either the coronary artery or the chambers of the heart, there would be massive bleeding and accumulation of blood in the pericardial sac, which is called hemopericardium. When this blood collection grows larger and larger, it would cause the heart to become unable to relax and fill up with blood due to its tamponade effect on the heart muscles. This is called cardiac tamponade. There could be arrhythmias as well, as trauma to the heart definitely could disrupt the conduction system of the heart, triggering potentially fatal arrhythmias. Let's see what happens further.
Hank, we need to cut your shirt off.
Cut the shirt, you're gonna buy me a new one.
You can have your pick out of our lost and found.
Ooh, how did this happen?
Framing nail incident with deep penetration of the left chest.
Look like?
Hank, you take medicine every day? Any allergies to medication?
No. Can you give me something for pain already? Is this a hospital or a vet clinic?
Very soon, Hank, very soon.
You say that to the beagle?
So, this is the ultrasound scan being done. Fast scan, which is focused assessment of sonography in trauma. Here I guess the depth of the nail and the likelihood of blood collection in the pericardium or pleura is going to be assessed.
Pulse 120 BP, 100 over 65.
A high pulse rate and low BP is consistent with a state of hypovolemic shock, where there is loss of blood, could be due to hemopericardium here. This could progress to cardiac tamponade, which would also typically cause low BP, muffled heart sounds, and distended neck veins, also called Beck's triad.
2 milligrams of morphine.
Liver GSW is in recovery. Good as new.
Whoa, that looks intracardiac.
Oh, nailed it.
Oh, you got jokes now.
No jokes, just pushing your pain meds, buddy.
Small pericardial effusion, but no evidence of tamponade.
Not yet.
Okay, so there's pericardial effusion. I guess more specifically, it would be called hemopericardium since it's likely a collection of blood here due to the traumatic nail piercing the heart and the blood pouring out from inside of the heart to outside in the pericardial space. And not just effusion or inflammatory fluid around the heart, as we saw in the cardiac tamponade case in episode 1, where fluid was removed via a syringe. However, it could eventually and almost certainly increase in amount to cause cardiac tamponade as well, because if the nail ruptured the heart muscle or an artery, the blood collection is only going to increase more and more within few minutes, which is what Dr. Robbie is referring to, saying not yet.
Talk to me. Do I need a priest here?
He's tachycardic with borderline BP. He could decompensate.
So there is compensated versus decompensated shock. What happens is when there is blood loss, here due to the hemopericardium, there is reduced blood volume and reduced blood flow to organs. At first, the body tries to compensate this itself by increasing the heart rate and constricting peripheral blood vessels to maintain the blood pressure. This state is called compensated shock, where the heart rate is high, which means tachycardia and blood pressure is normal or near normal. Now this could only occur for so much time. Eventually the body fails to compensate this and maintain the blood pressure, so the blood pressure starts falling and there is reduced blood flow to organs, which could potentially cause organ damage. This state is called decompensated shock. The patient here has a falling BP, so he is in a transitional state from compensated shock before to decompensated shock. If the systolic blood pressure drops below 90, we call it decompensated shock.
Stand by with 2 units, whole blood.
Usually in a case of hypovolemic shock, infusion with crystalloids like normal saline or Ringer lactate is given first. If it doesn't improve or a massive internal hemorrhage or blood collection is suspected, like in this case, then blood products are used.
Garcia here. It's not cardiac case.
Am I dying here and nobody's telling me?
Okay. There is blood collecting in the sac around your heart. You need surgery before your heart stops from the pressure around it.
Specifically, due to the pressure of the blood collection around, the heart stops relaxing first because the ventricle cannot expand during the diastolic phase of the heart cycle, where the ventricle is supposed to be filled with blood. As a result, there is reduced diastolic filling. Interestingly, this also means that when the ventricle contracts, it pumps less blood to the body because less was filled in the first place. This would cause even more drop in blood pressure, more backflow of blood in the right heart, which would lead to venous congestion and distended jugulars in the neck. Backflow to the lungs would cause pulmonary edema. This could eventually lead to a form of cardiac arrest called pulseless electrical activity, where patient has electrical activity in the heart but no pulse as there is no effective cardiac output. So it is a life-threatening emergency requiring immediate pericardiocentesis, that is removing the blood from the pericardium via a syringe externally. However, the surgery being referred to here is likely a thoracotomy for direct access to the heart, where the ruptured heart muscle would be sealed to stop further blood from accumulating in the space. Any other cardiac or vascular injuries are surgically repaired, along with draining the blood out of the pericardium.
Just pull the nail out! That would definitely kill you.
So the nail shouldn't be removed immediately because it's still lodged in the pericardium or the heart, because if you remove it immediately, the puncture site in the heart would open up even more, causing even more bleeding and would surely cause cardiac tamponade and cardiac arrest, which could lead to death. The nail itself is holding back some of the blood that could travel from inside the heart to outside in the pericardium if it was removed. So, this occlusion is to be maintained until the patient is surgically operated and the surgeon reaches the heart and is ready to seal the puncture site.
I want a second opinion. Where's my phone? I can Uber to Presby and find a real hospital.
Or I can take him in 10 minutes.
And if we intubate him first?
Sooner the better for all of us.
Great. 120 of Sux, 100 of ketamine.
So there are a couple of reasons why they want to intubate the patient here. First of all, the patient's cardiac output is going to get compromised due to the tamponade effect of the blood around his heart. The patient already has low BP due to significant blood collection here. He is eventually going to have tissue ischemia and hypoxia, which would in turn cause respiratory distress. Intubating the patient and minimizing the work of breathing while delivering oxygen directly into his lungs could help prevent the hypoxic tissue damage. Another thing is that the patient is going to require immediate surgical exploration, and that would require general anesthesia and intubation anyway. So, doing it in the ER would ensure that patient remains hemodynamically stable before the surgery, while also making the surgical procedure quick, as the first step of surgery, which is anesthesia, would be completed in the ER. Sux, or succinylcholine, and ketamine are drugs used in general anesthesia here, which is required prior to intubation.
Javati, you're up for this one.
Really?
Now, let's go. Move.
Lucky med student. She's going to get opportunity to intubate, which is great.
STEMI, ETA 5 minutes. Code STEMI, ETA 5 minutes.
I can start the STEMI with Mel.
So there is a case of STEMI, or ST segment elevation myocardial infarction, which means heart attack. The estimated time of arrival to the hospital from the ambulance is 5 minutes, which is quick.
I wanted to ask you about Tyler, the little boy who ate the marijuana gummy.
He's been admitted to pediatrics for observation.
And his parents?
They're upstairs with him. CYF is going to follow up with a home visit just to be safe, but no police were involved. Don't worry, no one's taking their child away from them.
Okay, that's a relief.
Okay, so this was a case of accidental poisoning of a child with cannabis. In cases of pediatric poisoning, the involvement of children, youth, and families, or CYF or Child Protective Services, may be necessary depending on the circumstances of the poisoning and the surrounding context. CYF's role is typically focused on the safety and welfare of the child and whether there is any neglect or abuse involved. They would typically follow up the child at home, assessing the child's safety at home, including interviewing family members. It would involve determining if there is a risk of future harm or neglect, and reporting the incident to the police if abuse is suspected.
Yeah, the parents, on the other hand, may need couples counseling after this. But I think little Tyler's going to be fine.
Yeah, the mother was too aggressive both to the father as well as to the treating doctors.
STEMI with me, Mel.
Right behind you.
Dana, what's open?
Trauma 2.
All right, keep it that way. Our target door to balloon time for STEMIs is 51 minutes.
The door to balloon time means the time between a patient with a heart attack or MI, specifically a STEMI here, arriving at the emergency department, which is the door, and for a catheter to be inserted and a balloon to be inflated into the blocked coronary artery as a standard procedure of treatment for MI. The procedure is called PCI, or percutaneous coronary intervention. Basically, the time it takes for a patient having a heart attack to be surgically operated for it and blockage to be relieved. The ideal goal here is to make it less than 90 minutes. If it's targeted to be less than that, like 51 minutes, it means that these doctors should provide emergency management to the patient as soon as possible and shift him to the operating room as soon as possible within 51 minutes, which is a big task ahead.
Ambitious.
But doable, as you're about to find out. Let's go.
Good view of the glottis. Eyes off the screen. Now look down the mouth and insert the tube around the bend.
You stole my med student from triage? How's she doing over here?
Doing pretty good.
Now look back at the screen.
We've seen intubation in episode 1 as well. These two whitish structures are the vocal cords, and the endotracheal tube, which is this right here, is to be inserted in between the vocal cords onto the trachea and sealed there. This is visualized with video laryngoscopy here. If this isn't available, we directly intubate the patient with a normal direct laryngoscope where we visualize the vocal cords from the laryngoscope itself like this.
And advance through the cords.
Good. Good job.
Thanks.
Pressure's down, 7238.
Effusion has grown. Now with RV collapse.
So, this hypoechoic collection here is the blood surrounding the right ventricle leading to its collapse. As we predicted, this has progressed to a case of cardiac tamponade, which is life-threatening and requires immediate intervention.
Pericardiocentesis?
No, I don't think pericardiocentesis would be the best here. Pericardiocentesis is a procedure where a needle is used to aspirate fluid, which is blood in this case, from the pericardial sac to relieve pressure on the heart. It is often used as an initial or emergency procedure to stabilize a patient with cardiac tamponade. However, here, since the nail has pierced into the heart for cases like penetrating trauma to the chest, causing ongoing progressive bleeding, the more appropriate and definitive procedure would be a thoracotomy that involves making a surgical incision in the chest to directly visualize the heart. Another thing is that this requires general anesthesia, but since the patient has already been intubated under general anesthesia, the thoracotomy would be quick and more definitive life-saving treatment here.
Get another unit on that infuser.
Prep for thoracotomy. Coming through.
With thoracotomy, surgeons can directly visualize the heart and pericardium, control the bleeding, and repair the heart or any affected blood vessels. The heart's perforation from the nail would likely require surgical repair, which means suturing or patching the injury. After the injury is repaired, any remaining blood in the pericardium is drained and the thoracic cavity is closed. The procedure also involves inserting chest tube for drainage of pleural space at the site of thoracotomy.
We should get back to triage. You don't want to stay for this? There were like 30 patients still waiting to be assessed out there. Okay. Did someone say thoracotomy?
Crashing from Tampa.
We can see the contrast between the humble med student who cares more about patients and an opportunist med student who would leave the normal patients for performing a procedure. But maybe that's the case because she wants to go into general surgery.
Dr. Garcia, do you think
Trauma surgery gets left-sided, thoracotomies. ED gets the right if we need to extend.
Regarding the types of thoracotomy, since it's a case of cardiac trauma, which is on the left side of the chest, a left thoracotomy is performed. Right thoracotomy would be done if the pathology or trauma involves right lung or the right side of the chest or requiring surgical access to esophagus or trachea or superior vena cava. Here, a left anterolateral thoracotomy will be typically performed in the 4th or 5th intercostal space.
Glove up, girl. You're on suction.
Let's advance that ET tube to the right main stem, please.
10 blade.
So here an incision is given from sternum to mid-axillary line in, I guess, the 4th intercostal space here for direct access to the heart and pericardium. This is called left anterolateral thoracotomy.
That's...
Dr. Santos, how do we cut through the intercostals?
So, the catch here is that the intercostal nerve, artery, and vein, which are also collectively called the intercostal neurovascular bundle, run beneath each rib in the costal groove. While cutting the intercostal muscles, the surgeon needs to always cut along the upper border of the rib below. This way, there would be enough distance from the neurovascular bundle, and the muscles in between can be cut safely without cutting the neurovascular bundle. The intercostal muscles should then be separated using blunt dissection, carefully avoiding the vessels or nerve. Also, the same thing applies when placing a chest tube as well. Insert the chest tube just above a rib to avoid vessel or nerve damage.
Through the superior rib to avoid the neurovascular bundle?
That's correct.
Finish that retractor.
This is the Finocchietto retractor, which is a rib spreader, used to carefully separate the ribs here and expose the heart.
Full suction. And get rid of this nail before I get poked.
On it.
So this is the beating heart. This is the point where the nail punctured the heart. The nail is being carefully removed here after the puncture site has been exposed. The accumulated blood in the pericardium has been suctioned here with the help of a suction tube. The ruptured heart muscles at the punctured site need to be sutured, and then any remaining blood would be suctioned out of the pericardium and usually left open. A chest tube would be typically put in the area of left thoracotomy for drainage of blood from the pleural space, either from the surgical process itself or from the pericardium in the future, which is left open. The pericardium heals itself over time.
Nails intact. In one piece.
Shoot forceps. Opening the pericardium.
Single puncture wound to the left ventricle. We've got a finger on it.
First unit is in, pressure's up.
Heart is filling well. Throwing a horizontal mattress and we're out of here.
Stop the bleed while I sew.
Horizontal mattress refers to the horizontal mattress suture here, which is a type of suturing technique used here to suture the ruptured heart muscles together.
STEMI's arrived.
You got this?
Just wrapping him up for OR delivery.
2 Proline on a tapered knee.
Proline 2.0 is the name of the suture material being used.
Mr. Ed Gellin is 52 years young with a history of hypertension and hyperlipidemia.
Hypertension simply means high blood pressure. Hyperlipidemia means increase in lipids, such as cholesterol in the blood. Both are common risk factors for formation of an atheromatous plaque in the coronary artery. This plaque ruptures and then completely blocks the coronary artery. This leads to death or infarction of the cardiac muscle or myocardium. Hence, it's called a myocardial infarction.
20 minutes of substernal chest pain.
Substernal chest pain means pain behind the sternum. Typical pain for a heart attack, often radiating to the left arm, jaw, or neck. Patients would often describe the pain as a crushing, pressure-like, or heavy squeezing sensation in the center of the chest.
10 out of 10 with dyspnea and diaphoresis.
10 out of 10 means the highest level of pain experienced. Dyspnea means shortness of breath, and diaphoresis means sweating, typical of the symptoms of myocardial infarction.
BP is 152 over 95, currently chewing 324 mg of beta.
So the medical management of a case of heart attack involves use of drugs like aspirin and clopidogrel. These are antiplatelet drugs, meaning they inhibit the formation of platelet aggregation and hence do not allow clots to form. So these are basically blood thinners. In the case of myocardial infarction, where the blood clot had ruptured to occlude a coronary artery and caused death of heart muscle, the use of these drugs would prevent the formation of further blood clots. Usually both aspirin and clopidogrel are given in doses starting from 162 and 300 respectively. Aspirin is to be chewed thoroughly and swallowed. Other medications would be a nitroglycerin tablet given sublingually, meaning kept below the tongue to be absorbed there, or available as a spray as well. It helps by relaxing the coronary arteries, which increases blood and oxygen supply to the heart. Morphine can be given for severe pain relief, and simultaneously, blood is drawn for sending cardiac enzymes like troponin I and T, along with CK, MB, which are markers of cardiac cell death.
Maybe aspirin.
Okay.
Blood's drawn, second IV started, UT stable.
This ECG shows ST segment elevation. This is the ST segment elevation right here, seen in multiple leads here. An ST segment elevation usually signifies a transmural myocardial infarction, which means death of full thickness of the cardiac muscles from inside out.
7 millimeters of ST elevation in the anterior lead.
These are sometimes called tombstones.
Tombstone ST elevation refers to a severely elevated ST segment in an ECG like this that resembles the shape of a tombstone, usually 4 to 6 millimeters on an ECG paper, but could be higher. If we look closely, we can see that in the leads V2, V3, and V4, there is markedly convex ST elevation, which appears dome-shaped like a tombstone. If this is seen in the leads V2, V3, and V4, which are anterior leads, it suggests a massive anterior wall MI, which means a large portion of the anterior wall of the left ventricle has died already. So, such type of massive myocardial infarction would naturally be associated with high mortality and poor prognosis due to risk of heart failure, arrhythmias, and sudden cardiac arrest and death if not treated rapidly. The door to balloon time here has to be as short as possible.
Open up, sir. Lift the tongue.
So they're going to give him the nitroglycerin in the form of a spray, sprayed under the tongue.
Mr. Gellin, you're having a very big heart attack right now. The major artery that carries oxygen to your heart is almost totally blocked.
So the artery he is referring to specifically is the proximal left anterior descending branch of the coronary artery that supplies the anterior and the septal walls of the right ventricle. Hence its occlusion here has caused the ECG change in the respective leads, signifying a massive anterior wall infarction.
That doesn't sound too good. No, it's not very good. We're going to send you up to the cath lab. A cardiologist is going to unblock that with a balloon and leave it open with a stent.
The definitive management of a heart attack is PCI, or percutaneous coronary intervention. It's a minimally invasive procedure carried out by interventional cardiologists to open blocked coronary artery to restore blood flow to the heart. Here, a stent is basically a small, expandable mesh tube used to keep the artery open. First of all, a balloon-tipped catheter with an expandable stent mounted on a deflated balloon is inserted into the radial or the femoral artery of the patient. This is then pushed up to the occluded artery under the guidance of coronary angiography and fluoroscopy to map out the coronary arteries. The occluded artery in this case is the proximal LAD. Upon reaching the site of the occlusion in this artery, the balloon is inflated that compress the plaque and opens up the lumen. This is called balloon angioplasty. This also expands the stent on top of the balloon, which then locks into the walls of the artery and keeps it open. After the stent is fully expanded and in place, the balloon is deflated. The balloon catheter is then removed, leaving the stent permanently in place to keep the artery open. This allows the blood flow to return back to the ischemic areas again and stop the progression of the infarction.
But I'm still having a heart attack? If everything goes as planned, it'll be like you never had a heart attack. I'm going to put a catheter in this artery right here.
He's referring to the right femoral artery, which would be the artery of choice here for the catheter insertion.
We're going to shave the hair with a clipper. Anybody we can call? My wife?
I already have her number.
Okay, we'll call her. You hang in there. I'll be right back.
Horizontal mattress in place with excellent hemostasis. Cut here.
They've sutured it. The emergently needed life-saving procedure has been completed in the ER itself.
Nice sterile towel, and away we go.
I spoke to cardiothoracic. They can meet you in the OR.
Good job.
The cardiothoracic team would likely close the incision and put a chest tube in the area of thoracotomy, I guess.
Coming through. Well done. Well done. Good luck, Mr. Gellin.
Thank you so much.
You're welcome.
The ER delivery to the OR here is pretty quick for both cases. Since just few minutes has passed, the door to balloon time here should be very impressive.
Coach Stemi was fast.
Time is myocardium.
This is a common phrase used in the context of a heart attack. It simply means every minute counts in treating a heart attack. Because there is progressively more death of myocardial tissue every single minute that's been spent in the ER, which is irreversible and can lead to extensive heart damage and death unless the blockage is surgically opened. The sooner the blockage is removed, the less myocardial tissue is lost, and the better the long-term outcomes for the patient.
And our statistics for door-to-balloon time get reviewed, critiqued, and published online.
Door-to-balloon time?
That's the time from when they hit our door to when the angioplasty balloon gets inflated in the cath lab. If we keep it to under 51 minutes, we can reverse a heart attack and save a life.
It's basically to be kept under 90 minutes. The goal is to minimize the progressive death of cardiac tissue as much as possible, as every minute counts here and could drastically affect the prognosis of the patient.
My parents both had sickle cell trait, and I was screened as a newborn with the hemoglobin FS pattern.
Basically, there are two hemoglobin genes on chromosome 11. Normal gene codes for HbA, which means normal hemoglobin. Now, if it's mutated like in sickle cell disease, it produces abnormal hemoglobin called HbS. If a person has one gene mutated and the other normal, it's called HbAs pattern, which means sickle cell trait. Here, the patient is asymptomatic as the normal hemoglobin encoded by one normal gene prevents sickling of RBCs. Her parents had sickle cell trait both, that is HbAs pattern. This means that she inherited abnormal gene HbS, one from each of the parents, to have HbSS pattern where there is full-blown symptomatic sickle cell disease like she is experiencing. Regarding the newborn state here, newborn has around 70 to 80% fetal hemoglobin called HbF, along with the remaining being HbS. This state would be HbFS, detected via screening. Interestingly, HbF persists for about 6 months after birth. HbF doesn't allow the cells to sickle despite the presence of HbS, so this means that the patient is asymptomatic till 6 months. After that, as the hemoglobin F gets gradually replaced with adult hemoglobin, but the hemoglobin produced here is HbS instead of HbA, there is HbSS pattern after 6 months.
Did you take penicillin?
Mm-hmm. Until I was 5, then the vaccines kicked in.
The penicillin being referred here is given for prophylaxis started by 2 months old in a baby with HbFS to prevent infections due to the sickle cell disease in the future. Why sickle cell disease causes risk of infections is interesting. See, the sickle cell RBCs are rapidly destroyed by the spleen, but also, due to the clogged capillaries in the spleen itself suffers from ischemic damage, meaning less blood supply to itself, and its tissue dies as a result. This progressive damage and shrinking of the spleen here is called autosplenectomy. Now, spleen is also responsible for clearing out encapsulated bacteria. These would be Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitidis. And so, these bacteria can't be cleared out, causing the risk of severe disease due to these, like pneumonia and meningitis. To prevent all of these, till 5 years they are given penicillin, a broad-spectrum antibiotic, and also vaccinated for these bacteria specifically, which are called PCV, HIB, and meningococcal vaccines. By 5 years old, most children have immune protection from their vaccinations, reducing their risk of fatal infections. So penicillin would be stopped after 5 years because after that, the immunity developed from the specific vaccines would be enough to prevent infections. However, penicillin could be continued beyond that as well in high-risk patients who have history of severe infections previously or live in high-risk areas.
As an RS3, you should be seeing at least 2 patients an hour.
I have to. Joyce and Mr. Wallace are good Samaritans.
Who's comatose and stable, you should have 4 by now.
I have the highest patient satisfaction of anyone.
I don't doubt it.
Why I wanted to comment on this scene is that if you are in a specialty where additional lives could be saved by spending time helping people in distress, you shouldn't be wasting time talking to patients who are already stable and out of their emergent situation. Actually, you would learn more if you saw more cases rather than dwelling on one case you found interesting.
But we just had this conversation a couple hours ago.
I know people call me slow-mo. You don't have to confirm or deny. It used to hurt my feelings a lot, but I can't help it. I work at the speed I'm comfortable at.
This is actually considered unacceptable in practical settings. Talking to an attending in the ER about how you don't want to see more patients because you aren't comfortable as an ER resident. In real life, if you say something like that and add the words, "I can't help it," you would be fired from the residency, and a person who is willing to adjust according to the patient flow to save more lives would be hired. And I am not supporting 24/7 work that burns out doctors, but realistically speaking, the ER shift just started and it's at hour 3, so it hasn't been that much time either.
Because you're afraid of making a mistake?
I'm always afraid of making a mistake, aren't you?
Yeah, of course I am, but you know what I mean. You make a mistake once and somebody dies and you feel so badly about it, you'll never let it happen.
How is that wrong?
Because you waste time and money on unnecessary tests. You keep sick patients waiting too long. You miss out on cases you could be learning from. You shortchange your own education.
That's pretty harsh, but this is due to the demand of the specialty like emergency medicine and the insane patient flow here in the hospital that makes this unacceptable. Same thing with internal medicine or surgery.
I'm not saying this to be a hard ass. I'm saying this because I know you can do this, but you need to do it at a level I also know you're capable of.
And what if I'm not?
Then you should look into a specialty that better suits you. Have you thought about psychiatry?
I don't want to go into psychiatry. I want to be here.
Being here means no matter how good you are or how hard you try, you're going to make another mistake. And someone else might even die. That's called being an emergency medicine doctor.
This is a case of not wanting to see patients from the start and going slow to avoid mistakes. More common than this, you sometimes get exhausted seeing patients every hour and every minute in the ER. But when you rest, you would always be thinking about the pending cases and worry. So I always used to work non-stop till the cases I was in charge get sorted and then take a breath or two and start seeing more. That's the nature of the ER.
If you can't accept that, then maybe this isn't the place for you.
There are specialties where you could be at your own comfort. Dr. Robbie gave a good example in psychiatry. Others could be dermatology, radiology, anesthesiology, and so on.
Is it good or bad?
If there's no spontaneous breathing, then carbon dioxide levels rise above 60.
So, the things that we've already discussed before are getting confirmed. Regarding the apnea test, we learned before that if any breathing effort is detected, which could be chest wall movement or accessory muscle use or nasal flaring, the test is stopped and we would declare that the patient is not brain dead. Here, there was no such effort shown. Now, after full 10 minutes of inducing high carbon dioxide levels, an arterial blood gas analysis has been done and partial pressure of carbon dioxide is measured. If it has increased to more than equal to 60 millimeters of mercury or 20 millimeters of mercury increase from the baseline without any respiratory effort detected, this means there is no brainstem response at all to revive breathing to clear the excess carbon dioxide out.
So 82. Definitely means that Nick's brainstem is not triggering him to breathe.
This means that even the rising CO2 levels, that is hypercapnia, is not able to stimulate the brainstem's respiratory centers to carry out spontaneous breathing to remove this excessively built CO2 from the blood and lungs. This means that the brainstem is unresponsive and has died.
Well, how can you fix that?
We can't. I'm sorry.
But with rest and time.
This is not something that heals on its own.
Death of any tissue is irreversible, but just like the myocardium, new brain tissue can't form to replace it. What's dead is dead, along with all of its functions. When the brainstem dies, there is no respiration. The respiration here is artificial, with the ventilator mechanically helping the patient breathe and aerate the lungs with oxygen to prevent from hypoxia.
There's got to be something else that we can do. Nick is our only child.
Is that test 100% accurate?
It is.
Isn't there anything else?
Once a patient is diagnosed with brainstem death, like in this case, he is legally and medically considered dead, even if their heart is still beating with the help of a ventilator. The heart is still breathing because it has its own pacemaker. When the ventilator would be turned off, the patient will stop breathing immediately, and then cardiac arrest would follow within minutes due to hypoxia.
We can do an imaging test called the cerebral perfusion study.
Then let's do it.
But you have to understand that would be the last test, what we would do.
This is an additional test to buy some time for the patient here. However, it's also a confirmatory test for brain death. Due to the respiratory depressant effect of fentanyl, he suffered from hypoxia. This caused lack of oxygen or hypoxia to the brain, causing it to die of hypoxic damage. Now, about the brain circulation, it's a little tricky here. The patient was bradycardic, meaning had low heart rate when he was brought to the ER. This is a response to the hypoxia compromising the heart itself. This could have also caused lack of blood flow to the brain, causing ischemic damage at the time of arrival. Heart rate was restored later. His heart is still beating till date, so there could still be blood flow to the brain because the heart is still working, but it's only a matter of time until the heart gives up and fails and goes into cardiac arrest eventually. Then the brain perfusion would be totally zero at that point.
If it comes back that there's no blood flow to Nick's brain, it would confirm beyond a shadow of a doubt that there's been brain death, which would mean that he's gone.
Then we wait and see.
Regardless of the perfusion results, it goes beyond doubt that the brainstem has already died due to hypoxia alone, which means lack of oxygen doesn't need to be ischemia or lack of blood supply. This is confirmed here already from the reflexes being absent and the apnea test. Also, it's just a matter of time until the perfusion becomes 0 too, if not already.
Call nuclear medicine, see how soon they can take him.
You got it.
I'll be back in a few minutes.
Thank you.
Nuclear medicine does these cerebral perfusion scans using radionuclide-like technetium.
Hey, Mr. Spencer in Central 9 tried to pull out his ET tube and is now in soft restraints.
No surprise there. We need to up the propofol.
An intubated patient trying to pull out the ET tube means that the patient has likely woken up from the general anesthesia being given, so the dose of the anesthesia needs to be adjusted to fully sedate the patient. Propofol is the name of a general anesthetic drug here.
Mr. Fulton in Central 14 just needs a shot of Mylanta for his GERD to avoid eating foods with the words flaming hot in their title for at least a few days.
Mylanta is the name of antacid containing aluminum hydroxide, magnesium hydroxide, and simethicone, which is used to relieve heartburn caused by GERD or gastroesophageal reflux disease. Here, there is reflux of the gastric acid from the stomach to the esophagus, causing intense burning sensation. The antacid helps neutralize the excess acid from the stomach and temporarily relieve the heartburn. It provides instant relief upon intake. There are also proton pump inhibitors, such as pantoprazole, that reduce acid production, to be taken before a meal, and yes, avoiding spicy, fatty, or acidic foods is a must.
Okay, thanks.
Shake it first. Oh, but make sure the lid is screwed down tight.
So, this is the Mylanta bottle right here. The antacid has a milky whitish appearance. This increases the pH of the stomach contents, making it more alkaline and reducing the burning sensation caused by acid reflux.
Okay.
Oh. I don't know about your mom, but I would not want mine working within 100 miles of me. No way.
My mother passed. She had a very aggressive malignant pheochromocytoma.
A pheochromocytoma is a rare tumor that arises from the adrenal medulla, which is the inner part of the adrenal glands. These tumor cells typically tend to produce excess catecholamines like adrenaline and noradrenaline. This would lead to symptoms like hypertension, headache, tachycardia with palpitations, meaning sensation of heart pounding in the chest, excessive sweating. Only about 10% of pheochromocytomas are malignant, which means they may spread to nearby lymph nodes or distant organs via bloodstream. These tumors tend to be very aggressive and spread to multiple organs early, with the metastatic disease associated with a poorer prognosis and survival rates.
Is there anything I can assist you with, Dr. Robbie?
I think we're best on our own right now, thank you.
He keeps trying to pull away.
We're giving him some more sedation.
Why is he so agitated?
He could have some awareness of the tube in his throat.
Waking up from general anesthesia while being intubated is not an uncommon occurrence, either in the ICU or in the middle of surgery, and usually occurs if the effect of the dose of anesthesia wears off sooner than expected. There is insufficient depth of anesthesia, meaning that dose is inadequate for the patient. The dose is to be immediately increased because the sensation of having the tube in the throat is extreme discomfort and sensation of suffocation due to the tube if the airway muscles aren't relaxed enough.
Or that he's in a strange place, or it could be lack of oxygen to his brain.
Does he need more oxygen?
He's on 100%. That's as high as it goes.
Hypoxia in the brain could definitely cause agitation or involuntary movements. You might be wondering, if he's given 100% oxygen, how could there still be hypoxia? The patient has pneumonia and pulmonary edema. Either way, the lung tissue has become severely inflamed and filled with fluids. This impairs the ability of lungs to transfer oxygen into the circulation while throwing away carbon dioxide. Lack of oxygen to the circulation would lead to hypoxia, causing potential brain damage. This drop in SpO2 could occur despite mechanical ventilation, with FiO2 or oxygen delivery at 100% here.
That is his blood pressure dropping.
Is that even fixable?
Normally, yes, with IV fluids, but we now know that that will just fill up his lungs, drop his oxygen even more.
This ties up perfectly with what we said before. There is fluid in the lungs. Providing more fluid to the patient could cause even more pulmonary edema. This would interfere with the oxygen and carbon dioxide exchange even more, acting as a barrier for gaseous exchange, which would lead to drop in oxygen in the circulation even more. Now, usually for pulmonary edema, we would give Lasix or furosemide, which is a diuretic, helping to remove excess water and excrete via kidneys. But the patient's BP is crashing, and giving Lasix would decrease BP even more. So this is a really tricky situation here.
Wasn't there something else we can do?
We can place a long, large IV catheter in his jugular vein down into his heart.
Just the gesture alone is enough to understand that he is talking about placing a central venous catheter. It's also called a central line and is a catheter placed into a large central vein, like for example the internal jugular vein, to provide long-term IV access for administering fluids, medications, or measuring central venous pressure. The other tip of the catheter reaches the superior vena cava directly, and then into the heart so the medications would circulate and act quicker as well. Also, you gotta understand that the patient's BP is crashing. This makes it difficult to administer IV medications via a peripheral venous catheter, as the peripheral veins shrink and collapse due to low blood pressure. So a central line has to be opened to administer medications.
And administer Levophed, which is a very powerful medicine, constrict his arteries, raise his blood pressure. But that could cause other organ damage, organ failure.
Levophed is the brand name for norepinephrine, a potent vasopressor used usually in the ICU to treat severe hypotension and septic shock, like in this case. It primarily acts by vasoconstricting arteries to increase blood pressure. Here, the peripheral arteries are selectively constricted, but the perfusion is still maintained to vital organs like the brain and heart. However, the catch here is that this is kind of like restricting blood flow from the periphery and diverting the blood to the brain and heart. And if this peripheral vasoconstriction becomes excessive, there would be reduced organ perfusion and then ischemia and tissue death in the periphery. And for the same reason, Levophed must be given via a central venous catheter, because if it leaks into peripheral tissue, it can cause tissue death due to vasoconstriction in the peripheries. Not only this, but even the insertion of a central venous catheter would have its own risks like infection or deep vein thrombosis.
I'm really sorry, but each new step is even more invasive, could cause more suffering with minimal benefit.
It's not only more invasive, it goes against the wish of the patient in question here, who wouldn't want to be poked further and would have never wanted to be intubated in the first place.
My son is dead, isn't he?
Brain death is medical and legal death.
I'm not a doctor, Mr. Bradley, but I do believe in God, and I am praying for your boy.
Mr. Bradley?
Vince?
No, my dad's gonna freak out. No, I know. I just needed to sleep. I thought I was.
Where did you get the drugs?
Who are you?
Did you give them to my son? Did you give my son drugs?
Mr. Bradley, you can't come in here. Mr. Bradley, please, let me
is
help
this?
you
Tell
out
me
of
the
here.
truth.
Security!
Nick's dad. Did you drug
Where the hell's
my
security?
son?
Your son gave me the drugs. Ask him.
He's dead. And you are on fire. You killed my son. You killed my son.
Alright, so it looks like the cases of fentanyl overdoses are interconnected here. Counterfeit Xanax was bought by a bunch of high schoolers from the same source without a doctor's prescription and abused it for its sedative effects. Xanax isn't really the preferred treatment for insomnia. It's mainly prescribed for anxiety for its calming effect. It's also not prescribed for regular use because of its high risk of addiction and dependence. It's the misuse, abuse, and addiction of Xanax for its sedative and euphoric effects that's being exploited here by the teenagers. The counterfeit Xanax contained fentanyl in doses enough to take the life of the abuser here. Fentanyl is 100 times more potent than morphine and 50 times more than heroin. The dose of fentanyl in the pill was enough to completely shut down the respiratory system of the boy, causing enough hypoxia leading to brain death before even Narcan could reverse its effect. The girl here is lucky that she was found by her friend. An immediate reversal with Narcan saved her life. Otherwise, she would have met the same fate as the other guy. So, never use drugs without a doctor's prescription. It's both illegal and unethical to do so, and now it has become a fatal mistake as well.
Oh, was it from when you killed that guy?
Hey, I did not. That guy had a massive MI in his sleep.
Relax, Huckleberry. I'm just fucking with you. Truth is, you're not a real doctor till you've lost at least one patient. You got off easy. It wasn't your fault. Not all of us can take comfort in saying that. But try not to kill anybody else.
This character here is trying to send a message to all the aspiring doctors, or basically everyone in any field, to avoid people like this as much as possible. I do understand that sometimes it's not possible to avoid, and you have to interact in some way or form. They would demoralize you when you are at your lowest by telling exactly what makes you upset, and envy you when you are provided opportunities. So, don't waste your energy towards negative people.
What am I looking at?
Mr. Bill Philbin, 46. He tripped while walking his dog.
He saw a squirrel, and it's my wife's dog. Damn thing doesn't even like me.
Clearly. Where's the dog now?
Hopefully in a kill shelter.
This is a case of head trauma. Primary management with bandaging has already been done. I guess fast scan, CT head, might require CT for the whole body depending upon how the fall was.
I'm sorry. I just want to understand how this could happen to our son. I can't stop wondering why Nick and not her.
The difference here between the two cases is that the girl was found in the state of arrest quicker than the guy. The girl's respiratory depression was reversed completely by Narcan, but the guy's wasn't, simply because a lot of time had passed already for the poor guy. At that point, he had suffered enough brain tissue injury due to hypoxia already. We got a note here that Narcan is going to antagonize the effects of fentanyl by binding to the opioid receptors and inhibiting the fentanyl's action on those receptors. If fentanyl already caused enough respiratory depression and hypoxic damage to brain, Narcan can't reverse what has already occurred. It would prevent further effects of opioids on the brainstem. But if the brainstem has already been damaged, Narcan has little effect, and hence the patient had to be intubated. And now, the patient has died.
I can't help it.
I think it would be helpful for you to speak with our department social worker. Would you two be open to that?
None of this is fair.
No. No, it's not.
But he's still breathing.
Yeah, but it's due to the ventilator mechanically providing breaths, pushing air into his lungs under positive pressure and mimicking actual respiration. If the ventilator would be turned off, not only his breathing would stop, but his heart would also go into arrest and stop due to hypoxia.
The ventilator's breathing for him. Brain death is the same as death.
What about that last test that we're waiting for?
I can almost guarantee it'll say the same. I'm so sorry.
When there's already a clinical diagnosis and an apnea test confirming brain death, the perfusion study result have little to do. After all, that perfusion to the brain, even if it's there, would stop if the ventilator is turned off.
I wish I could have done more to save your son.
There's only so much that a doctor can do sometimes, and sometimes, in critical patients with poor prognosis, additional procedures or tests or even medications hurt them instead of helping them.
Ask Dana what's open for morphine and order an x-ray, okay? Copy. Hey, closed injury, forklift versus foot, forklift 1.
Got it?
Closed injury means that the skin is intact here, meaning there is no open wound or break in the skin of the right foot. However, there could be damage to muscles, bones, or ligaments. Could be fractures too, in which case we call it a closed fracture as opposed to an open one. So an x-ray is required.
Any luck reaching David?
Not yet.
Did you try calling the school?
He didn't show up for class.
Any idea where he might have gone? Friends, relatives?
We don't have any family in state. And David, he doesn't associate with anyone.
Teresa, do you think that David would try to hurt any of the girls that are on that list?
No,
Do you remember some of the names on that list?
not really.
Maybe you could try.
If you haven't seen episode 1, the medical aspect of this case was that this was a case of malingering where the mother consciously took ipecac, an obsolete emetic drug, to induce vomiting and make herself appear ill for secondary gain, which in this case was so that her son would get counseling as he has been thinking about violence towards others.
How's she doing?
She's worried sick about her son. What are you going to do?
I thought he would come back after Mom called him. Hey, what are the ethics about me reaching out to him under the guise of a medical emergency with Mom?
If he's a danger to himself or others, I'd argue you have a professional responsibility to do whatever's necessary.
Okay.
If there is a genuine risk of harm or violence, the doctor has an ethical obligation to prevent harm. This may involve taking steps to address the potential threat. Best thing would be to contact the authorities for a possible threat in the son and leave it to them, even if it means the boy would face consequences in the future. At least he would improve.
Hey, can you come talk to the parents of the OD kid that we brought in earlier? 18-year-old, brain dead from a fentanyl overdose.
Oh, jeez.
Yeah, only child, and I just think that the parents could use a little help processing what they're going through.
Parents losing their child, that too single, is a very disturbing experience, and witnessing it is very painful as well, especially if it involves use of drugs that they should never have in the first place.
What about donation? Is he a candidate?
The transplant counselor could get him there, but I think we're a ways away from calling them in.
I'll see what I can do.
Thank you.
So, one of the reasons for continuing to keep a brain-dead patient on life support here would be organ transplantation, as the organs would be preserved if kept on a ventilator under oxygen to prevent hypoxic damage. Organ transplantation would be possible here if the family consents.
But if one of those disgusting things bites a patient and we get a case of hantavirus, guess who's going to have to answer for that one? Chief.
Aren't they?
A rat bite can potentially expose someone to hantavirus, although it is relatively uncommon for transmission to occur directly through a rat bite. Hantavirus is typically transmitted through contact with rodent urine, droppings, or saliva, or by inhaling aerosolized particles contaminated with these materials. People can also be exposed if they come into direct contact with these substances, like cleaning up rodent-infested areas. While the virus is carried in rodents, bite transmission is very rare. If someone is infected with hantavirus, initial symptoms can include fever, fatigue, muscle aches, and headache. As the infection progresses, it can lead to hantavirus pulmonary syndrome, which affects the lungs, causing shortness of breath and low blood pressure. This can be a life-threatening condition requiring immediate medical care. If you are bitten by a rat, it's important to clean the wound thoroughly with soap and water to reduce the risk of infection, including bacterial infections from the rat's mouth. You gotta avoid exposure to rodent urine, droppings, or saliva. Wear gloves and a mask when cleaning areas with rodent activity like this ER right here.
Hey, been looking all over for you. We need a cardiovert unstable AFib in North 1.
Okay, just give me a sec.
Systolic's 90.
So, AFib, or atrial fibrillation, refers to a type of heart arrhythmia where the atria or the upper chambers of the heart beat rapidly and irregularly. AFib is said to be stable if the patient doesn't have signs of hemodynamic compromise, meaning his BP is normal with no signs of shock. In such case, rate is controlled with beta blockers like metoprolol, and then rhythm control is considered with pharmacological cardioversion, which means use of antiarrhythmic drugs like amiodarone to restore the normal heart rhythm. But if the patient does have such signs like low blood pressure with systolic BP less than 90, or signs of shock like cold, clammy extremities or heart failure, then the AFib is said to be unstable. Here, rapid cardioversion is required. So in such case, synchronized DC cardioversion is the treatment of choice. It simply involves delivering a controlled electrical shock to the heart using a defibrillator. Electrodes or sticky pads are placed on the chest to deliver the DC shock, which is timed to coincide with the heart's electrical activity, hence called as synchronized.
Me. 35-year-old architect working on a deadline, vaping nicotine all night, palpitations this morning, AFib at 147. Mr. Quinn, this is
Palpitation refers to the sensation of heart pounding in the chest. Heart rate in a fib could be above 300 beats per minute. It's important to note that the atria or the upper chambers are fibrillating at such a high rate, and this sends less blood to the ventricles, so the cardiac output is actually reduced here. Nicotine vaping can be associated with AFib, because nicotine can either trigger or worsen or prolong AFib as it increases heart rate and could trigger abnormal electrical activity in the atria.
Dr. Robbie.
Hello, sir. How you feeling?
Like crap.
When did your palpitations start?
A little while ago. We interrogated his smartwatch. His heart rate's only been up for 92 minutes.
You understand we need to shock your heart back to normal?
Is it gonna hurt? He'll be sedated.
So they are preparing the patient for synchronized DC cardioversion. And yes, sedation and analgesia are required for this, with anesthetic drugs like propofol and analgesics like morphine.
It's really gonna hurt.
Mel, 75 of propofol, slow IV push.
How much did you vape last night?
A couple of pods.
Vape every day?
I do, but not that much.
Want to cut back?
I try, but it's just really hard.
How much nicotine is in a pod? Anybody know?
No idea.
40 milligrams, same as a pack of cigarettes.
He's performing an ultrasound of the heart. In case of atrial fibrillation, an echo would be useful to assess for chamber enlargement. Typically, in case of fibrillation, the left atrium is dilated. It helps check for any other pathologies like valvular heart disease that could worsen AFib. It also helps to evaluate left ventricle function and ejection fraction. We gotta first understand here that the atrial chambers in atrial fibrillation are just fibrillating like a bag of worms and are not effectively contracting at all. This means that since the blood hasn't effectively been pushed into the ventricle, there is pooling of blood in the atrium. Now, this stagnation of blood leads to formation of blood clots in the left atrium, particularly in the left atrial appendage. These blood clots, also called thrombi, can disseminate throughout the body, and in the brain, the blood clot, now called as embolus, obstructs cerebral blood vessels leading to stroke. This event is called thromboembolic event, and the stroke is called thromboembolic stroke. So it's important to prevent this from happening by cardioverting as soon as possible.
Wow, 2 packs in one night.
Mel, what's the safe window for cardioversion?
12 hours.
What happens after that?
Increased risk of embolic stroke from left atrial blood clot.
Studies have shown that cardioversion performed within 48 hours of onset of atrial fibrillation has a lower risk of stroke afterwards. It's even lower if performed within 12 hours, as being eluded here. The risk of thromboembolic events is higher when cardioverting atrial fibrillation that has lasted longer than 48 hours. It's important to note here that anticoagulation with drugs like dabigatran is recommended in a case of atrial fibrillation to prevent this very formation of thrombus and prevent the risk of stroke afterwards, based on stroke risk using a specific score called the Chadds-Vask score in the patient.
Left atrial blood clot.
Which he does not have.
So I don't think a left atrial blood clot is seen in the bedside ultrasound done here. A bedside ultrasound or a transthoracic ultrasound cannot detect blood clot in the left atrium. Most clots form in the left atrial appendage, which cannot be visualized on a bedside ultrasound probe applied to the chest, because this appendage is located deep in the chest, behind lung and ribs. All it can show is the atrial enlargement here. Now, to visualize the left atrial blood clots in the left atrial appendage, a transesophageal echocardiography is required. Here, the ultrasound probe is placed in the esophagus, which is directly behind the left atrium and the left atrial appendage. So the probe can visualize the left atrial appendage without interference from ribs or lung. So to correct this, a transesophageal echocardiography is done before cardioversion to check for left atrial thrombus in the left atrial appendage. If a clot is found, cardioversion is delayed and anticoagulation is required first, as there is high probability of stroke occurring. The ultrasound done here in the scene can only detect atrial enlargement or blood stasis, which could only raise suspicion of a clot, not visualize it. Also, another thing is that a transesophageal echo isn't really required in all cases before cardioversion. We could do it only if the onset of AFib has been more than 48 hours, at which point the suspicion of clot formation would be high. Here, it's within an hour, so clot formation is very unlikely.
Mr. Quinn. Mr. Quinn. Okay, he's out. Sync cardioversion at 200 joules.
Sync cardioversion means synchronized cardioversion. This means that controlled electric shock to the heart is given in synchronization with the R wave of the QRS complex to prevent inducing ventricular fibrillation, which is another type of arrhythmia.
Charged.
Clear. Bingo.
Sinus rhythm?
Sinus rhythm means that the heart rhythm has been restored back to normal.
Cycle BP.
We'll monitor for a few hours.
Yeah, let's get addiction services on the case, too. He's going to need a daily patch of nicotine gum for breakthrough cravings. This one's a bitch to kick.
Nicotine patch and gums are both nicotine replacement therapy options used to reduce withdrawal symptoms and help with quitting smoking and controlling cravings. These provide a controlled dose of nicotine without the harmful chemicals found in cigarettes. A nicotine patch is applied to the skin, which delivers constant nicotine through the skin daily to maintain the baseline nicotine. Gums are chewed for fast-acting nicotine boosts for relieving cravings.
You looking for something in particular?
Anything with a very low potential for mortality?
Mm-mm. You're not playing that game.
Only thing I'm playing is let's keep the patients alive.
Uh-huh. Well, now we're playing Face Your Fears.
That sounds like a terrible game.
What up there scares you the most?
All of it.
Pick the worst.
South 20, 82-year-old woman, low back pain. I mean, that's potential leaking AAA, caught Aquinas syndrome, spinal epidural abscess.
So here, there is history of an 82-year-old with lower back pain. With this history, the first thing I would suspect here is a degenerative disease like osteoarthritis of the spine, where there is degeneration of the joints between the vertebrae, or senile osteoporosis, where the bone mineral density decreases with age, causing weak spine prone to fractures. Then, maybe if there's fever, we could think of infectious causes like osteomyelitis, which means infection of bone, and epidural abscess, which means collection of pus in the epidural space of the spine. There could also be metastasis of tumors on the back causing chronic back pain as well, which becomes an often late diagnosis of cancer. AAA means abdominal aortic aneurysm. This means a localized bulging of the abdominal aorta. The larger the aneurysm, the more likely is that it could rupture and leak. However, the rupture would be characterized by a sudden severe pain in the abdomen or back and would be a life-threatening surgical emergency with a hemodynamically unstable patient requiring immediate surgery and vascular repair. The other differential he alluded to was cauda equina syndrome. Here, the nerves at the lower end of the spinal cord, called the cauda equina, are compressed, leading to a myriad of symptoms like severe low back pain, numbness, and loss of bladder and bowel control. This is also a surgical emergency requiring immediate decompression. So, if the patient is stable here, these are very unlikely diagnoses.
That could go wrong in so many ways.
Not today, amigo. We're gonna work this lady up like a race car.
What does that mean?
Means you're on the pit crew now. Come on.
I really can't look at this letter. Would it be too much for you to ask you to read it to me? Oh, I'm sorry. That's inappropriate.
No, not at all. Not at all. I'd be honored by the request.
I think this is the case the ER physician at the night shift was referring to as a war vet who died due to being hit by a drunk driver. And this must be the letter written by Dr. Jack to the family of the deceased.
To the family of Raymond Orser. My name is Dr. Jack Abbott. I am the emergency department physician who treated Raymond. I, like Ray, am also a veteran, and though I never met Raymond before today, I served with men like him, so I can only imagine what an outstanding person he must have been. I'm sorry I could not save Ray's life. We worked on him for several hours, but his injuries were too severe, even for someone as tough and battle-tested as Raymond. Please take some comfort in knowing he did not suffer. You have my heartfelt condolences, Jack Abbott.
So, this letter, along with the scene at the start of the series where Dr. Jack is on top of a building staring down and talking about quitting his job, is a reflection of the deep emotional trauma that doctors face seeing deaths of people every single day in the ER or ICU. Seeing such deaths and not being able to save the patient's life creates a feeling of guilt as to whether I could have done things differently or if I didn't do enough to save the patient. This wears you down over time, leading to burnout, depression, and even thoughts about taking your own life. Many doctors quit their job, and some even took their own life during the time of the pandemic, where patient deaths were common in the ER and ICU. Especially working in the ER, ICU, and neurosurgery would inflict such emotional trauma, which makes you question the meaning of life and how short it could be, and make you realize that life's absolutely unpredictable.
Excuse me, doctor. My father's starting to struggle again.
Okay.
What can you do to make him more comfortable?
So, the patient is uncomfortable even after increasing the dose of anesthetic drug propofol. Usually, dose adjustment does the job.
We can take the tube out.
But he needs that to breathe.
If we extubate, we would keep him on oxygen for comfort. It would decrease his sedation. He might regain consciousness. He could recognize you, maybe even speak.
But he might also go into respiratory failure, respiratory arrest, and die as well. The reason why he was intubated was due to him being unable to sustain a normal SpO2 otherwise. He was in respiratory distress and failure, and now likely heart failure as well, as the cardiac output has decreased with low BP. He would more likely not be able to sustain spontaneous breathing if the ventilation assist is removed by extubation.
Well, I don't want to do anything to jeopardize him getting better.
That's just the point, Helen. He's never getting better.
You don't know that.
I do know that. Okay, he knows that. And Dad probably even knows it. It's time to let him go.
I'm sorry if you've had your fill of Dad, but I haven't. And I am not giving up on him.
There's a valid reason for turning off the ventilator here. This has already gone well against the patient's wishes, and the whole point of the advance directive was not to struggle like this at the end stage of life.
Even if it's hurting him? I'm sorry, but if there was anything I could do to heal your father, I would do it. But the most humane thing that I can do for him is to allow him a painless, peaceful passing. And that requires removing the breathing tube.
How long will it take once the tube's out?
From minutes to hours, but we would ensure that he'd be in no physical discomfort.
Yeah, the comfort care is to be provided here even during the stage of cardiorespiratory arrest like oxygen or fluids. I guess the statements in his advance directive was like a do not resuscitate. Comfort care. However, they did resuscitate by intubating him though, going against a valid DNI.
Okay.
This scene reminds me of countless deaths of critically ill patients in ICU under ventilation, which made me question, was it even worth the ventilation and everything that was done after that? Because at the end of the day, the patient is gone, thousands of dollars are gone, and worst of it all, the patient didn't have a peaceful death at all. A typical critical patient in an ICU is likely poked several times. He, like many patients, has a catheter injected into his neck to deliver meds, and he has a tube inside his throat the whole time, while being totally unaware of what is happening to him. After being sedated, such patients basically never woke up, which begs the moral and ethical question of, was the critical care worth it if the patient never even woke up, while his body was being poked in every way possible the whole time? Another thing is that the families often want everything to be done that's medically possible, without leaving any stone unturned, even when the chances of survival are low. Families are often left watching their loved one go through prolonged suffering and struggle with uncertainty. Advances in medicine do allow us to prolong life, but not always with good quality, and sometimes like this, without the patient ever waking. Sometimes interventions continue because we can, rather than because we should. ICU care or ventilation care does not necessarily change the outcome. So, patient counseling regarding the likely outcome is absolutely crucial, and it has been beautifully done by Dr. Robbie here throughout the care of this patient. Was it worth the hassle? This is a philosophical question to ponder over for all doctors and healthcare providers after seeing expensive medical care and unpeaceful deaths despite the care in the medical field. That's something to share openly to the patient party directly before even admitting them to the ICU and not provide false hopes and expectations. Thank you so much for watching. If you've made it till here and you're still listening, I can't express how much that means to me because this took a very long time to make. I hope you enjoyed it. Please comment if I should make the next episode or suggest any other series or drama or basically anything like this on the internet that requires a medical breakdown, and I shall happily do my best. Once again, please support the channel by liking, sharing it to your friends, and subscribing to the channel.